Okay, good afternoon, everybody. Let's get started with SEVA VentRounds. Today's May 31st, 2022. And we're going to be talking about volume or pressure control. This is maxing number 3, and we'll see some examples that will help us understand this concept. And so let's get started. We discussed particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion, and it does not represent the Cleveland Clinics. Here are disclosures for both Rob and myself. This is a recorded session, so keep your microphone muted. We may call upon members of the audience to comment, but mainly use the chat. If you put it on the chat, we will read it out loud, and if we have questions, we'll ask, and if not, we will comment as it comes. And as usual, the employees of the Cleveland Clinic get CME with a QR at the end of the session. All right. So this is the maxing number 3, and we have Rob here who will talk to us about the essentially the third maxim, which is you can only control one side of the equation. You can only control pressure or volume. Rob, you want to?
Yeah. Historically, respiratory care, and I would say pulmonary physicians in general, have thought of modes of ventilation as being either some form of volume control or pressure control, because the way it evolved, people could either set a tidal volume and the patient would always get it, or you would set some kind of inspiratory pressure and the patient would always get that. But as ventilators and modes have evolved, we need a little bit more precise definition. And in order to get that definition, we have to base it on some sort of theoretical framework. We just can't make things up as we go. So as it turns out, there is a mathematical model that has been in use in pulmonary medicine way back since the 50s, and is also, and by the way, has been borrowed from electrical engineering. In the electrical engineering world, resistances are called resistance, and compliances are called capacitance. They operate the same way an electrical circuit says those things operate in the human body. So anyways, this model is fairly simple, at least it looks simple, and it's called the equation of motion for the respiratory system. And it looks like an algebraic equation, but in fact, it's a differential equation that was derived from calculus. And believe it or not, the godfathers of pulmonary physiology, they were mathematicians. They knew all this stuff, and so they were familiar with using this equation, like Otis and Mead and those guys. And anyways, we have used it. We've adapted it in a simpler form to be the theoretical framework for selecting modes of ventilation. So this wraps us up just to say that the equation says that pressure, volume, and flow are continuous variables of time. They change constantly with time. And the parameters of elastance that we see in blue here and resistance are constants. They don't change. These are properties, mechanical properties of the respiratory system. And essentially what we're saying then is that you can only control one side of the equation at a time, which gives us the theoretical foundation for saying that a mode is either a form of pressure control because we're controlling the pressure waveform as a function of time, in which case volume and flow depend on the mechanical properties of elastance and resistance. Or if we control the other side of the equation, that there's two things over there. That means we have to preset both the tidal volume V and the inspiratory flow with the V dot. And therefore the pressure on the left-hand side becomes dependent on the mechanical properties of resistance and elastance. And of course, the elastance represents the lungs and the chest wall, the distensibility of those things, and the resistance represents the flow resistance of the airways and any artificial airways that we have in place. So that's a long-winded answer, but I think it covers basics. Oh, and one other thing, what you're showing here, the waveforms that we see on ventilators or that we show when we're doing graphical analysis, those waveforms are nothing but the equation of motion graphed out. Pressure, volume, and flow, again, are continuous variables of time, and if you plot them over time, you get these waveforms.
Excellent. Thank you, Rob.
Mhm.
And so what we're going to do now is we're going to see some examples of how you control the pressure control or volume control. So along with our usual readings of the waveforms, and these waveforms have a fair amount of information as usual. As the other item that is a little bit new and that we have been adapting recently is, as you know, we have the first step is to read the tag. The second one is to identify the load, which is exactly what Rob is talking about with the equation of motion and knowing the resistive load and the elastic load as well as PMOS. And then the patient ventilator discordance, and we go in order by the trigger, inspiration, cycle, expiration. And lately we have been adding at the end the volume waveform, so that because there's information on the volume waveform that which may be important for the situation of the patient. So I'll just add it there. And I wonder if any of our team members is interested in reading this and taking it, giving it a stab.
I am interested in Dr. Mireles.
All right, Dr. Smith, please guide us through the process.
All right, so at least looking at the waveforms here, I think the suspicion is always that the ventilators are pretty good at controlling flow and not that great at controlling pressure. That being said, I think that this is VC CMVS, just on the basis of what the waveforms look like. As far as the load goes, I don't see any patient effort. You know, I think without a square waveform, it's not very easy to see on the inspiratory thing. So I don't think I'll comment on what the load is inspiratory wise. Expiratory wise, I think the load is primarily elastic, just based on there's a fairly quick return to baseline. As far as trigger discordance goes, I don't really see any PMUS here, so I would say this is probably a normal trigger. It's the waveform is a descend. I guess it's still flow control, but it's a descending RAM. So I don't think it's any work shifting. I think it's normal. Again, I think the cycle is also normal because the patient is not really involved there, and then expiration is also normal. And as far as the volume waveform goes, it's a pretty sizable leak somewhere in the circuits. I'm not exactly sure where exactly described. And I guess as far as going back to the load again goes, I guess I could be convinced that it's more resistive than elastic. So I'm gonna change my instance to resistive instead of elastic.
Okay. Any other comments? Mike, you're good?
I'm done on my end.
All righty. So there's a lot of truth in your words, and so let's just do some comments for those that are wondering how you came to that conclusion. And I purposefully, intentionally, I cut obviously the tag of the mode on the top, and I cut almost everything, although I left a little bit of a hint there, but it doesn't really matter. But absolutely, this is volume control. I think that may cause disturbance on the force, and you trying to read through it is all these irregularities that you can see on the flow waveform and actually on the pressure waveform. It doesn't look smooth and nice as it should, but there's a lot of irregularity. The other thing that, but they're essentially pretty similar in conformation. And then if you look at the volume, the volume waveform is exactly the same height, which could happen without a doubt in pressure control. What is missing here is the descent, the exponential decay that you would expect if it's pressure control, like you would see over here. This is the waveform from a pressure control mode, and then you can see over here a flow decay. Now, and I don't know why they don't have done this on the ventilator, and Rob perhaps has the answer, but they could potentially, if they wanted, have an exponential decay on the flow waveform being controlled by the machine, but they have not chose to do that. They just did it linear, and I don't think that there's a good reason for that, but it's an interesting item. that would really sabotage us. Then it would be hard to know exactly what you're reading, but this is a good marker of why this is volume control. Rob, comments?
Just that when you have a descending ramp, and in this case, the flow goes down to 0 at end inspiration, then that provides a little bit more information, knowing that that's volume control, because at the very beginning of the breath, the initial pressure is all due to resistance because no volume has been delivered yet. And at the end, the pressure is all due to elastance because flow is now 0. So if you just go back to the equation of motion, you'll see at those 2 points in time, you either have a volume signal or you have a flow signal. And so the pressure is related to those two things. So getting back to what you said, Mike, that this looks like a resistive problem, that might be suggested by the fact that the initial pressure was higher than the final pressure.
Yeah, that makes a lot of sense. Thanks.
Yeah. So, and this is one of those classic signs that we see that when you're walking in the unit, if you know that your patient is on descending ramp and you see the peak higher than the end of the breath, then that's a marker that it's either that the flow is set very high or that the resistance on the patient is elevated. So when you see this pattern over here, higher at the beginning and then lower at the end, in a patient that is passive with no PMOS, this is consistent with high resistance. And then I confirm it by going and looking at the expiratory flow and see how the expiratory flow returns to baseline. Now, this patient has a little bit of a sabotage. Number one, the gain on your flow may not allow you to see it at this amount. So the scale may need to be increased so that you can see the difference in between the baseline and the expiratory flow. That's one of them. And the second one is that if the patient has a large leak, you may not actually be able to see the flow because the air has escaped or through another hole that is not going through the sensor that you're looking for. And so I would put those as potential that that you read is actually most likely resistive as you highlighted there. Rob, any other comments there?
That's a good point. When you have a leak, the leak is basically a resistance connected to an infinite compliance, which is the sky, right? So that resistance of the leak is in parallel with the resistance of the respiratory system, and resistors in parallel add such that the total resistance is less in any arm. Another bit of math that we stole from electrical engineering.
So the CMB, you're absolutely right. All the breadths that we see here, there could be another algorithm hidden here, but at least on this screen, we don't see any spontaneous breadths, and all of them are mandatory. And knowing that this is, I mean, you can recognize the type of ventilator that it is just by looking at the screen. This is a Servo U. And so if programmed appropriately, this would be an S, a CMB S. But it could change to different types of algorithms depending on what you activate on the ventilator. So good job, Mike. A classic item is any patient ventilator discordance. In this case, there's no patient activity or nothing that the ventilator is reading as patient activity, which essentially negates the presence of discordance. And then these aberrances, these movements that we see on the waveform, you can see how they are pretty routine in their or regular on their presence, and that makes you suspect that this is cardiac oscillations just because of the synchrony that they have or periodicity that they have. And finally, the only thing that I would say is when you look at the waveform for volume, remember that this square root sign has several causes. One of them is a leak. So I would keep that as, I mean, this looks, it's most likely a leak, but it's important for you to recognize that this could be air trapping or a sensor that is not appropriately placed, or a leak as you highlighted there. So just highlighting that. Any other comments from the team? Questions?
So I had reasoned, and you could tell if my reasoning is correct or not, that since flow, I guess, was able to get pretty close to zero, that made air trapping a little bit less likely. Although I guess you can still have flow reaching zero and still have air trapping. But that was my reasoning for thinking more leak.
So one of the key items to recognize is that in auto PEEP or air trapping, the discrepancies on exhaled air are temporary. The ones that you have reached baseline, you will not see that discrepancy unless the patient is actively increasing the frequency or something. So if you see that this is a patient that has no activity, no patient activity is static, as you can see, it would be, unless they have changed the frequency, and these are the first two breaths, you should not see that discrepancy, or you should not expect that as a marker of auto PEEP. Does that make sense, Mike?
Yes.
Yeah, plus if you could blow up the scale for flow, you might actually see a small inspiratory flow during that period. It could be 2 or 3 liters a minute, but you can't tell now the way it is. And the other thing to keep in mind is that in volume control, inspiratory waveform, volume wave, and flow waveform are controlled, but during expiration, it's always pressure control. So the patient could exhale as much as they want, more or less than they got in.
Makes sense.
So just to summarize, and this is how I like to think about this at the bedside. So let's translate this to the bedside. Is you have a patient that is on volume control, with no evidence of patient activity, with increased resistance and presence of a leak, an air leak. And so under these circumstances, I'm gonna just put a question to you, Mike. If your goal was safety, that means maintaining gas exchange or preventing ventilator-induced lung injury, is there something that you would change on this ventilator, or actions that you would ask the team to do?
Well, obviously I think some clinical context would be helpful. Although my assumption in this case is this is either someone that has COPD with a pneumothorax or ruptured bleb, or or someone that's maybe has undergone an endobronchial valve with a pneumothorax as well. I guess my thought would be, in order to be able to safe and maintain gas exchange to someone with increased resistance, would be to try to decrease the respiratory rate a little bit. Again, to make sure that they don't end up developing any further leaks, and maybe also reduce the volume that's going through the pneumothorax.
And remember that would be a pneumothorax with a chest tube.
Yes, with a persistent air leak through the chest tube. Yeah.
So that's one. So that now you're starting to see how you put in this case you put a COPD, right? So now you're concerned. Well, he has a high resistance. He has a bronchopleural fistula. How do I deal with this with the ventilator? How do I adjust the settings to deal with either the leak from a bronchopleural fistula, or to decrease? And you can imagine that if this was a bronchopleural fistula and the patient had an increased resistance, you probably want to reduce the auto PEEP on this patient, right?
Yeah, as much as we could. Yeah.
So let me ask you, in a patient with a bronchopleural fistula or a leak that you cannot get rid of, what is best? What would be the best mode for a patient under those circumstances? Volume control or pressure control?
Oh boy. I'm not sure the answer. That's a good question. Well, I guess the tidal volume here is set fairly high, I would assume, just seeing as looking at least the things down there.
550.
Yeah. I guess in my this is again the venturing a guess. I'd want to make sure that I have enough ventilation to guarantee good gas exchange while minimizing the amount of flow that goes through the leak. And therefore, if I could do that with pressure control, and I can assure that he is actually ventilating okay with pressure control, I think that'd be probably the best way to minimize the amount of flow that goes through the BPF.
So you're choosing volume?
I'm choosing pressure.
Pressure, all right. I have one person on the chat going for volume. Anybody else that wants to go volume or pressure? There's only two options. Have no fear. We'll give them a minute to answer. All right, there's Equipoise here. We have volume and we have pressure coming through. Rob, do you want to give it a shot?
Yeah. First of all, you have to understand that even if you're in volume control, the lungs are only seeing pressure control. The lungs are always seeing the pressure drop across the resistance. So if the resistance happens to be at the level of the trachea, because let's say you have a leaky cuff, then the flow through that resistance gives a back pressure, and that's the pressure that the lungs see. It's not the pressure that the ventilator sees. So you're always in pressure control, but if you have it set in volume control, you don't really know what the pressure control is, what the inspiratory pressure is at the patient. The other thing is with volume control, you have by definition a preset tidal volume. So some of that tidal volume is going to go out through the leak. Whereas if you were in pressure control, you could feed the leak essentially. And that's the way we have historically thought about ventilating neonates, because they don't have cuffed endotracheal tubes. And pressure control has historically been preferred there because you can feed the leak as much flow as it wants and still maintain safety of gas exchange for the patient.
So meaning you're able to, if you think about this, the way that I imagine this, and please Rob correct me if I'm wrong, is that because you apply the pressure, you can inflate the whole lung at the same time, and the extra flow that is needed goes out to through the BPF or the hole that you have, so you can maintain the size of the balloon by putting more pressure, and you can inflate it as much as you need because the flow will escape. But if you give volume control, the amount that it will inflate and the areas that will inflate will be affected because you're going to have a large amount leaking through the hole, and you're not going to be able to inflate the rest of the lung. So it will give you a more even inflation of the
It's easier to control. They're both iffy because you don't know exactly what you're controlling, but it's easier to manage with the pressure control mode, especially if it's a positional leak, right? Which is a big problem in neonates, and maybe not so much in adult with a chest tube, but yeah.
Very good. All right, so pressure for holes. Very good. Excellent discussion. Any questions before I move to the next one? Comments, sadness? What about just bad COPD without the leak? So a patient that has just high resistance, what would be better, volume or pressure? So in these circumstances, is there anybody wants to share volume or pressure? Not that there's.
I think I would choose volume myself, just because I think more of that being an asthmatic patient rather than COPD is when we truly get in trouble. I would just have more control. I mean, regardless the rates that I will have to use for those patients, if it's a truly bad scenario of dynamic, like dynamic air obstruction, then I will eventually need to drop the rate so much that the patient will be uncomfortable regardless, and most likely would need to be deeply sedated. So the more comfort of pressure wouldn't matter much here. The second thing is, I feel like I would have more control as well in terms of I would be able to maximize the flow, and kind of that would decrease the eye time as much as I can, besides obviously decreasing the rate and everything. And the last thing is the ease of being able to monitor the peak versus the plateau as well would give me more reassurance and everybody more reassurance, because we're going to be seeing high pressures regarding with those patients, and everybody will be freaking out about the peak pressure. But the ability to easily monitor the plateau pressure would be helpful for everybody to kind of be reassured that we're avoiding lung injury.
So all good comments. I think that what you're talking about is the variability of the resistance. So the altering resistance can either cause hypoventilation or very large tidal volumes in patients as they resolve, and your manifestation of somebody with worsening bronchospasm would be if you're on volume control, it would be an increasing peak pressure, right? And that increasing peak pressure will signal, oh, he's having more, or the patient is having more resistance. Sorry, somebody left a phone here. And so the increased resistance would be that's how you detect it, but you would ensure that the patient is getting the tidal volume under those circumstances. But these are patients that are sedated, and essentially you don't have any muscle activity, any PMOS. That's why we prefer volume control under those circumstances. Once that they start recovering and getting into more of the comfort, then it's a different situation. But in the safety, I think that volume is the way to go. Any other thoughts, Rob?
Keep in mind that we're just assuming pressure control with set point targeting.
Yes.
You got adaptive targeting, you can set a target tidal volume, and other things being equal, you could do exactly the same thing as you could with volume control.
Absolutely. Absolutely. All right. Let's take a look at another one, and I'll ask for any volunteers that wants to give it a shot, have an opportunity to read any of the team members. Anybody wants to give it a try? Right. So we'll read it ourselves. So let's start by what's the tag. And so when we start with this, remember first what are we controlling? And there's a pretty good hint here as you read this, that the flow, if you notice the flow between the first breath and the second breath, they are very different. Actually, you will realize that on the first one, the peak flow is higher than on the second one. In the first one, it starts having this little difference on the flow, and then it has this exponential decay that seems very exciting. On this one, it has a decay and then it increases, so the flow is not being controlled. And then if you go up to see the pressure, you can see that the pressure has some abnormalities, probably related to what we're seeing below, but it's essentially at the same height. So this is because we are not controlling the flow, then you would have to be controlling the pressure. The second item is what type of breath sequence we have here. And at least on these two breaths that we can see here, we can see that one of them is triggered by the patient and is cycled. And we don't know exactly what cycles it, but at least on this figure, the flow did not reach zero. And then on the next breath, this is a machine-triggered breath. You can see that there's no patient activity or signaling from the ventilator. And then there is evidence of patient effort. And actually, I can see even a patient effort continuing at the end of the breath. And we're going to talk about this at the end. But that tells me that this is a machine cycled breath. And because these two are the same length, this has to be continuous mandatory ventilation until proven otherwise. And just for the sake, because we don't have more information and there's only two breaths, I'm going to say that this is set point, meaning the most basic type of pressure control. In terms of the load, whenever I'm controlling pressure, that's why it's important to put the tag first. My next, if I'm controlling pressure, I look at the flow. And we commented at the beginning that there is evidence of PMOS. So there's evidence of of effort, and actually you can see the patient was doing a fair amount of effort, finally triggered the breath, and we see a little bit of patient effort, and then the patient relaxes and it doesn't reach zero. It just continues to decay, actually exponentially, and then it shuts off the breath. In this one, I see only PMOS. So I see a little bit of PMOS during inspiration in both breaths, in this one and this one. But when I go and look at the expiratory phase on this breath, it actually looks like it's pretty prolonged and it doesn't reach zero. You can see it's 1, 2, 3, 4 seconds, and there's still flow. You can still see the line, the baseline, which makes me think that this individual has increased resistance. There's other features here that may make me think about that, which is it didn't reach zero flow over here. And this one it seems to be just effort from the patient. So I think that until proven otherwise, I would think that this patient has increased resistance. In terms of patient ventilator discordance, let's start by breath number 1, and we can see, I mean, it has a feature here. You can see the baseline, and I like to paint where the kind of think of it, where does the PMOS started? And you can see how the patient was going from exhalation, and then it starts moving towards baseline, and the pressure starts actually going down. So it seems that the breath, the PMOS started all the way over here, and ends more or less over here. And I think that that's where it ends, because I stopped seeing that instead of the nice decay that we should be seeing. I see some activity, some PMOS. But it took the ventilator a fair amount of time. You can see how much it decayed in the pressure. And it is because it's pressure triggered. It's triggered right here by pressure. So the first breath, I would say, is that it's a late trigger. So it took from the onset of the PMOS. Actually, you can see how the flow, let me erase this, the flow crossed the baseline. You see how it crossed the baseline. And it's the flow was above baseline, and the patient was not getting the breath because of the way that the trigger was set. So the first one is definitely a late trigger. But if I go to the second breath, I see the classic pattern, which is a mandatory breath. So it was started by the machine. And then as the breath goes, you will see that suddenly there is an increase in flow, which is all of this should have been decaying. All of this is actually PMOS, and you can actually see the corresponding drop of pressure on the breath right there. So when you see a mandatory followed by a patient, that is called an early trigger. So the first one is a late, the second one is early trigger. In terms of inspiration, and actually, there's an interesting thing here. As you can see, this one is a passive one. The second breath, the beginning, is a passive one. And now look at the difference on peak flow between one and the other. And this tells you that the patient was doing a fair amount of effort, or was doing effort. That's why it got more flow, because until this point, it kind of opened up started pressurizing the patient. And you can see as the patient is doing effort, how the peak flow is almost at the same high over here, just telling you that the patient is doing about the same effort during this. So there's a degree of work shifting without doubt on the second breath, but I'm going to put this work shifting with an asterisk, and I'll talk about that in a second. And then in terms of cycle, on this one, on the second, the first breath is normal, the cycle is normal, but then the second one, you see that feature that instead of seeing the peak flow go all the way up like that, right? You see that that's missing compared to the prior one and to this one, and that tells you that the patient was actually inhaling, still doing inspiratory effort when this cycled off. And so technically this is an early cycle. And again, I'm going to put an asterisk. And the reason why I put an asterisk on these two is because the driver for this abnormality, for the work shifting and for the early cycle, is the first, the early trigger. So we only classify one of them, because if you start classifying every single one of them, you end up with a melee of things. And so in this case, an early trigger, essentially, we expect there to be some work shifting. And there it may come with or without an early cycle. Then during expiration, I think that this is normal. This looks normal. This one, there was some amount of work, expiratory work here. So I'm gonna put on the pre one or whatever. And the volume, actually, this is a good, in volume. Just look at the volume waveform, and this may be illustrative for all of us. How the patient was exhaling, then took another breath in with a lot of effort, got this amount of inspiratory volume, so got from here to here an inspiratory volume, and then exhales, and actually the exhalation is much more than the patient inhaled, and so we cannot see. We lost it from the scale. It's gone. So that may, and that probably happened because the patient had air trapped from these two breaths that are here, one after the other, and then the patient was able to exhale, and then got another breath with effort on top of it. So just a manifestation of where we are. I'm gonna stop there. Rob, comments?
Yeah, just to add to what you just said, ventilator volume waveforms reset every time flow crosses zero. So you don't actually get an accurate picture of what's happening in the lungs. So you can have a much larger volume in the lungs at end inspiration than the ventilator is showing, like this situation.
Yeah, actually, this is a good example of potentially air trapping, right? This breath that happened right here, where I put reset, is that the patient took a breath, it's exhaling, and you get this square root sign, but that doesn't necessarily mean that there's a leak. It may be that the patient took a breath right on top of the other one, and then exhaled this the extra air that was inside the air, so you couldn't see it. Excellent point, Rob. Thank you. What else? Questions from the team? So let me ask you a question, because this is a common, and Ariel had brought this up on our last, when we did this in Spanish. So you come by and you have this patient, and you see this abnormality and it's occurring. So if your goal is safety, it looks like safety, what would you do? How do you deal with this? Anybody? Yeah, so yeah, so this is pretty cool. So we're seeing the two paradigms occur right now. So the road divides into two pathways in my mind, and I'm gonna say one road is to sedate more, to paralyze more, and the other road is to decrease the rate or even decrease sedation. And you're gonna say, what is this guy talking about? Yeah. So let's think a little bit about this. And when you see this, there's a couple of hints that tells you that something is happening with this patient. That is, this is a pattern that we saw very often during the COVID pandemic, and we continue to see. But I think that you'll get aligned with what I'm going to say now. So the first hint that I have here is that the patient is on a pressure trigger. So that's the first hint. The second hint is the presence of reverse or early trigger, which in this case may be reverse trigger etiology. So when we see that there's a pressure trigger, this usually means that the respiratory therapy therapist or clinician, the physician at the bedside, has been dealing with a patient that is having something that they don't like. And usually what they don't like and you can see it here on the second one, when there's a reverse trigger, this patient had early cycle, and you can see how much it dropped the trigger. This patient could have potentially triggered another breath and get a double breath here, double trigger or multiple trigger. And so one of the ways that the team gets rid of it is by changing to pressure trigger and put it hard enough so that the patient cannot trigger another breath. Even though they will have early trigger, that's one of the signals. So when I see this, then I stop and I think, well, what is the cause of reverse triggering? And we don't know much, and I'm going to go out on a limb, and this is recorded, and so it's for posterity. But I would say that in my mind, the majority of these abnormalities of rhythm that we are seeing, either entrainment or the actual kind of reflex trigger of a breath after a mandatory breath, are probably a manifestation of toxicity of sedation that we're using, sedation and analgesia. And that many times we try to deal with them by increasing the sedation, even though the patient is completely out for the count. And that leads to more of this. And we enter this cycle of more sedation, more paralysis, because the patient continues to have reverse or early trigger with double large tidal volumes. And that's all probably toxicity of the medulla from the propofol, opiates, benzos that we kept giving. One of the ways that we have dealt with it is by decreasing the rate and letting the patient take its own rhythm. The other one is by decreasing the sedation and just biting the bullet and letting the patient get untoxic after several hours. They come back and the medulla starts triggering on its own. But to be fair, there's no good evidence, at least to my knowledge at this point, to deal with that. And so many times we end up having to make a decision if the goal is safety and the patient is generating very large tidal volumes or very large PMOS, is to paralyze the patient. And I'm being careful here when I say paralyzed, because many of these patients are already at a RASS of -5. And going higher on it will only make them more toxic in my point of view. But just putting it out there for comment. I'll see if there's any comments. Rob, any comments here or anybody else?
Ariel said, make a long expiratory pause to see what happens. If you do a long expiratory pause, that could unmask a PMUS effort. But that's what you would expect to find if you drop the rate or drop the sedation anyways.
Yeah, and there's a group of patients. That's why I'm not within these early cycle, early trigger individuals that have reverse triggering. I don't think that there is a unifying pathway on them. There's some of the patients that respond to dropping the rate and the reverse trigger disappears. And there's other group of patients that you drop the rate and they actually continue to have kind of a reflex. It's not a rate dependent entrainment. It's a mandatory breath triggered PMOS, and that doesn't go away with a dropping rate. So good points. Any other comments from the team? Yeah, so that's a great question, Mike. So if the patient is in a situation in which you can stop the sedation, the question is, will that go away? This is all, I mean, we don't have a randomized controlled trial to prove this, but there's reports, and we have seen it here, as we wake the patients up, that goes away, because that's the etiology. Now, this is an evolving field. I'm going to make that very clear. This is an evolving field, and we are still trying to figure it out. But based on the clinical observations of the last 2 years, I think that this is more related to sedation than to to something else, and it's driven by our aim to try to control those synchrony process and the tidal volume in patients with severe ARDS, and as they are emerging, you start seeing these mechanisms. But this also highlights the fact, and we cannot, that's why this is such an evolving field, is what's the mechanism for somebody that is coming, that has what we call reverse trigger and they're brain dead, and how does that actually work? So we need to learn. I mean, the first animal model was published this year, and so that will help us understand a little bit better how this works, this type of desynchrony. All right. Any other questions? Very good. Really, really good discussion for this one. It's not a simple one. Well, we have 13 minutes. I think we can do one more. But before I show it, I want to see if there's somebody that wants to give it a try. All right. So let's start. Rob, do you want to give it a try to this one? This was submitted by Ariel.
Yeah.
It's very cool. I'll just show it for the team. On the top, you have the PCO2. Remember that this ventilator highlights triggering by the triangle that you can see right here, yellow triangle. You can see the airway pressure. You can see the flow, and you can see volume on the bottom waveform. So Rob, it's all yours. You want to give it?
Okay. Looking at the flow waveform, as I tend to do, we see some distorted, what looks like rectangular flow waveforms and one that is not. So we have a nice rectangular flow waveform that would suggest to me, when you look up at the airway pressure, that that's a form of volume control. I'm going to say volume control, probably probably CMV, because the distorted flow waveforms still look like it's trying to be volume control, but the flow is dropping. It's not constant. So I'll say volume control CMVS, because I don't see any indication of anything being done automatically here. Tidal volumes are consistent. So yeah, pretty confident at volume control CMV. The load, well, primarily we're seeing massive PMUS on these breaths where the flow waveform's got that little notch in it. You see that the airway pressure drops way below baseline, and baseline seems to be pretty high, like 20 centimeters of PEEP. So we're seeing a massive inspiratory effort. The pressure goes way below baseline, and then as the volume is delivered, it goes above baseline. So that's PMUS work shifting. On the expiratory phase, I would have to say that looks pretty normal. If anything, it might be a decreased elastance. I mean, the increased elastance, decreased compliance, because you're getting flow returning to zero. Looks like passively within about a second and a half, if those are second marks along the horizontal axis. So probably an elastic load there on expiration. And of course, it's there on inspiration. You just can't see it that way. As far as triggering, we see the little triangle marks for most of the breaths. We see at the top of the waveform, what we have not seen before is the exhaled CO2, the capnogram. So we have a waveform for every triggered breath and one for non-triggered breath. So what that would indicate is the patient was exhaling CO2, but he didn't get it from the ventilator. So that could be an indication of a missed trigger. Again, inspiration is work shifting, cycle. These are mandatory breaths. I don't see any indication of abnormal cycling. Expiration is normal. Yeah.
Yeah.
So Ariel says that this was the mode called S in parentheses CMV or synchronized CMV. I think it's a confusing name, but it is volume control CMV S.
I think this is a very nice graph for many motives, Rob, but just highlighting, we're controlling volume. And one of the common things that people get concerned when you see this is that you see, instead of seeing a rectangle, you see a change on the flow. And that is just to highlight, remember that in this ventilator on the Hamilton, the sensor is actually at the Y. It's right here before the ET tube goes into the patient. So this is the ET tube. And this is the inspiratory limb, the expiratory limb, and the sensor is right here. And so you will see changes in flow that because of changes in the actual flow that crosses the sensor because of the compliance of the tubing.
The patient circuit, you mean? Yeah.
Circuit, sorry, of the tubing, yes. And so the patient is generating so much negative pressure that you can, I mean, I presume that if you were at the bedside, you would see that the tubing oscillate in size as the patient essentially is like a straw that it's sucking it and it's collapsing its walls. And so you see that change. And actually this serves essentially as a marker of the length of the breath, that you can see that the breath goes from here to here. And you could argue, Rob, and I want to hear your thoughts. I mean, this is appropriately triggered by the patient, and it cycles right here, and so you have still this amount of time in which the breath has cycled. Why is this not a late cycle?
Well, you could argue that it is a late cycle because perfect synchrony, the flow coming out of the ventilator would match the flow, the PMOS waveform. So yeah, I stand corrected. I would call that a late cycle based on the patient's evident PMOS.
Right. And this causes a little bit of challenge in my brain, because you can imagine if you just trigger, even if we didn't have this work shifting, if it had just triggered, it would also be a late cycle. And you remember we had this conversation when we were doing the classification of saying, well, when does it stop being a late cycle, right? Because if it just triggered and it was a normal trigger and then the rest of the breath, the patient was passive, it would be technically a late cycle. But it's something that has to be defined in the literature of saying, well, when is it a late cycle? When there's evidence of PMOS, when there is evidence of too much PMOS that occupies how much percent of the breath. And I don't have that completely defined so far.
Yeah, I think that strictly speaking, if the P vent isn't exactly the same as the PMOS, there's a synchrony problem.
Yeah. Very good. Questions in the audience?
I guess when you look at the breath that was completely triggered and cycled by the machine, and you can see, I don't think there is necessarily evidence of active exhalation during the inspiration. So kind of back to your point, you know, if the patient isn't actively exhaling during inspiration, does that mean that it's not late cycling, or is it just the mere fact that, hey, the inspiration is longer than the patient neural time, right? Then it is a late cycle.
Yeah, so and you can imagine, I mean, this is the issue of why we need a consensus statement and a little bit more research of coming to terms and saying, well, how and when are we going to call it? Because if you did an asynchrony index on this patient, the number of synchrony issues that you would highlight would be increased by the number of late cycles if you were calling that part of your issue, as well as the the work shifting and the degree of work shifting that exists. So this requires a little bit more, it's more nuanced than what we do here. And I want to highlight that as part of the disclosures, is that this is an evolving nature of how we classify and understand the synchrony issues or discordance issues with the ventilator, and how do we study them. That not all of the late cycles are the same thing, and not all work shifting is the same. There's different degrees, and we have to understand how to measure it and how to record it. All right, any other comments? All right. Well, thank you all for thank you, Ahmed, for your input, Michael, for your input, Rob, as usual, for being here, and Ariel, and we hope this was educational for all of you. Have a good day.